Okay, I think we'll get started now. Hello, everyone, and thanks for coming to my presentation. For my presentation, I chose to review some of the relatively recent developments in the treatment of Alzheimer's disease related to dementia, particularly treating Alzheimer's disease with anti-amyloid monoclonal antibodies. There was a landmark study recently, Clarity AD, which was presented in November 2022, and it was published in the New England Journal of Medicine in January 2023, which received significant media attention. I was interested in reviewing some of the literature surrounding this, as despite all the media attention these drugs received, I've not seen them incorporated into clinical practice just yet, and they've received mixed reaction from clinicians and researchers alike, with some having a very positive response and some having a more pessimistic response. I'm hoping by the end of my presentation, you have a better understanding of the current public health issues we're facing related to dementia and Alzheimer's disease, the current available therapeutic options, the mechanism of action of these novel anti-amyloid medications, and whether this is something clinically relevant and potentially practice-changing versus something we should be more cautious about. I don't have any disclosures to make. We'll go quite quickly through the first half of the presentation. It's just to provide some background information. So dementia and Alzheimer's disease is a disease of the elderly, and given our aging population, it's one we're going to need to work to address. Dementia is currently the 7th leading cause of death worldwide, and it's costing global economies $1.3 trillion per year. Specifically in a Canadian context, 25% of individuals over 85 have been diagnosed with dementia. And the number of those being diagnosed with and living with dementia in Canada is in excess of our population relative to the rest of the world. Also, women are twice as likely to have dementia and also are more likely to be the primary caregiver of an individual living with dementia. So this disease affects them disproportionately. Specifically in Canada, those with dementia have 65% higher rates. In Canada, those with dementia have 65% higher rates of hospitalization and therefore higher healthcare utilization than those without dementia. And individuals with dementia have longer stays in the emergency department, about 2 to 2.5 hours longer than those without dementia. This data from Canada was back in 2015 and 16, so it might have changed since then, likely has progressed. They also have longer hospital stays. For example, individuals who are 65 to 79 with dementia have hospital stays twice as long as those without. They have higher rates of unintended hospital-related harm during their hospital stays. They approximately have 1.5 times higher rates of complications, such as urinary tract infections, dehydration, aspiration pneumonia, and delirium. And Alzheimer's disease is by far and away the most common cause of dementia, contributing to 60 to 70% of cases. The pathophysiology of the development of Alzheimer's disease is quite complex. It's an interplay of many different factors. However, hallmarks typically include amyloid beta subunits and protofibrils developing into insoluble plaques, as well as hyperphosphorylated tau proteins that form these neurofibrillary tangles, resulting in oxidative stress, neuronal loss, and decreased cholinergic transmission. And so here are the different factors that have been implicated in the development of Alzheimer's disease: amyloid plaques, neurofibrillary tangles, and this idea of cholinergic insufficiency. There's a few other factors at play that we won't get into. And from a therapeutic standpoint, drugs to date have largely targeted a decline in acetylcholine transmission. So specifically, patients with Alzheimer's disease or Alzheimer's dementia have a reduced cerebral content of choline acetyltransferase, which leads to a decrease in acetylcholine synthesis and impaired cortical cholinergic function. Cholinesterase inhibitors increase cholinergic transmission by inhibiting cholinesterase at the synaptic cleft, and that's the idea behind these medications. So here's a list of the current approved medications for the treatment of Alzheimer's disease, including cholinesterase inhibitors, as well as memantine, which is an NMDA receptor antagonist, which works a bit differently. In terms of the specific benefits, after about 6 to 12 months, these medications lead to a modest clinical improvement. Specifically on the 70-point Alzheimer's disease cognitive assessment scale, it leads to a difference of about 2.7 or 3 points. And on the MMSC, a difference of about 1.37 points. So it's a huge scale, 70-point scale, and it's a difference of about 3. There's also numerous side effects associated with these medications, particularly GI side effects such as nausea, vomiting, diarrhea, and they're also associated with behavioral disturbances in bradycardia. Because of all these side effects, approximately 1/3 of patients discontinue therapy within the first 6 months due to side effects, forgetfulness, or perceived lack of benefit. The number needed to treat for cholinesterase inhibitor for minimal improvement is 12. The number needed to harm for any adverse event is also 12. And for significant improvement, you need to treat 42 patients. And while these drugs do work, studies have shown no significant benefit regarding delaying entry to institutional care. Many patients show no observable benefit of these medications. One reference I found suggested as many as 30 to 50% of patients don't respond. Patients also with rapid decline have been shown not to benefit, which are some of the most vulnerable patients who need treatment options the most. And despite a mean change of 2.7 points on cognition testing scores, some sources list a minimum 4-point change in the ADAS-Cog, which was the scale used to be held clinically important. However, a certain subset of patients, up to 20%, show a significant response to these medications. So it really comes down to a patient-by-patient case on who will and who will not benefit. And the response is very heterogeneous. I think the heterogeneity is highlighted by a quotation I came across frequently when I was reviewing the literature. It said that if you've seen one patient with dementia, you've only seen one patient with dementia, which I think really stresses how individualized the responses are to pharmacologic therapy, as well as their clinical course. As you see, some patients have a very significant response and some patients no response at all or significant side effects. Memantine is an NMDA receptor antagonist. I won't go into too much detail, but the NMDA receptor is activated by glutamate, the principal excitatory amino acid neurotransmitter, in cortical and hippocampal neurons that are involved in learning and memory. And it's thought that excessive NMDA stimulation can lead to excitotoxicity, and that by blocking pathologic stimulation of these receptors, you may protect against further damage in Alzheimer's disease. It's only used in moderate to severe dementia, and while patients do score higher on MMSE and lower on scales measuring functional impairment, the average differences in scores in the studies that looked at this medication didn't meet pre-specified thresholds considered to be clinically important, and so there's very limited benefit to memantine. Often it's used because it has a different mechanism of action of cholinesterase inhibitors. So for patients who have poor side effects to that, it's another option. But based on the modest and varied clinical response with cholinesterase inhibitors and the minimal benefit of NMDA antagonists, as well as the degree of public health impact from dementia and Alzheimer's disease, there's a clear need for more effective pharmacologic therapy. And that leads us to the relatively new target for the new generation of medications in Alzheimer's disease, to target the specific pathological changes we see, which is the formation of these amyloid beta plaques and neurofibrillary tangles I was talking about earlier. So these plaques form from the breakdown of amyloid beta precursor protein, which is an integral membrane protein expressed in many tissues and concentrated in the synapses of neurons. It functions as a cell surface receptor and has been implicated as a regulator of synapse formation and neuroplasticity. And studies have shown that an imbalance between amyloid beta synthesis from the metabolism of this protein by gamma secretase and alpha secretase and beta secretase, as well as there's an imbalance between the synthesis of these protein aggregates and clearance, eventually leads to protein misfolding, aggregation, and extracellular accumulation of eventual insoluble amyloid plaques. The hope is that by targeting these amyloid beta peptides and subunits, is that we can prevent the formation of these plaques and reduce or prevent clinical decline. Over the last 10 to 15 years, there have been multiple attempts at different monoclonal antibodies targeting these proteins. And there's been numerous studies. Most of them have not been shown to be beneficial or the side effects have been too great. The most recent of these drugs is lecanemab. Just prior to lecanemab, there was a drug called aducanumab, which was very controversial. So lecanemab was interesting because it was the first treatment for Alzheimer's disease to receive approval by the FDA since 2003. It was considered a first-in-class medication, and it actually received accelerated approval, which is a unique pathway developed through during the HIV epidemic to allow faster approval of drugs that fill an unmet medical need that require an extended period of time to study for serious life-threatening conditions. The faster approval relies on the use of surrogate endpoints of a specific treatment, In this case, it was a reduction of amyloid plaques that may correlate with a real clinical endpoint, but does not necessarily guarantee clinical efficacy. Although the FDA usually follows an advisory committee's recommendations, there was a recent investigation by Congress in the US that found the FDA decided to approve this medication under the accelerated approval pathway, even though none of the 11 members of the advisory committee reviewing the drug recommended the drug for approval. The investigation found that the FDA inappropriately collaborated with the drug maker when it granted accelerated approval, and it was released in June 2021, despite concerns raised by experts about inconsistencies with the drug's clinical data. The FDA also gave the drug a broad label, allowing it to be used in patients with Alzheimer's disease of all degrees of severity, even though it had only been tested up to that point in patients with mild cognitive impairment and mild dementia. 3 of the panelists who voted against aducanumab's approval resigned in protest from the advisory committee, and this kind of colored the whole class of these medications, and there was a lot of pessimism surrounding these anti-amyloid drugs around this time. Ultimately, Biogen, the drug maker, who's also involved in the drug development of lecanemab, the drug we're going to talk about, withdrew this drug in January of 2024, citing financial reasons, but the whole process, like I said, was very controversial. So that's kind of what led us up to Clarity AD, which was, as I said, presented in November 2022 and published in the New England Journal of Medicine, January 2023, looking at this different monoclonal antibody than previously had been looked at lecanemab in early Alzheimer's disease. So lecanemab was felt to be different than some of these other drugs that they tried because it targets these protofibrils, which are felt to be the most toxic and having the most toxic effects on neurons. So Clarity AD was an 18-month multi-center, double-blind, placebo-controlled parallel group trial. It randomized patients to either receive lecanemab or placebo. Patients were stratified according to clinical subgroup, whether they had mild cognitive impairment or mild dementia, ApoE4 carrier status, which we'll talk about a bit more, and geographic region. The primary outcome of this study was a change from baseline at 18 months in the clinical dementia rating scale sum of boxes score. They looked at secondary outcomes as well. They looked at the degree of amyloid plaques seen on PET scan, the ADAS-Cog, which was the testing used on the old cholinesterase inhibitor studies that we previously mentioned. ADCOMS was a composite score of the CDR, the ADAS-Cog, as well as the MMSE, as well as a scoring system measuring ADL impairment. I won't go into each scoring system in detail, but specifically for the clinical dementia rating scale, which was their primary outcome, it looks at 6 different domains: memory, orientation, judgment and problem solving, community affairs, home and hobbies, personal care, and you get a score of 0 to 3 in each category for a total score of 18. In terms of the inclusion criteria, it included patients 50 to 90 years of age. It only had patients with mild disease, so mild cognitive impairment or mild Alzheimer's disease-related dementia. They had to have amyloid positivity, so they had to have a PET scan or either CSF measurement of amyloid beta prior to being enrolled in the study. They had to have objective impairment in episodic memory, as well as MMSE scores of 22 to 30. In terms of the exclusion criteria, if patients had any other neurologic conditions, they weren't included in the study. History of CVA in the last 12 months, any psychiatric conditions. Patients with contraindications to MRI were excluded from the study as well because of some of the adverse effects of these medications, which we'll talk about in more detail later. And if patients had any vascular malformations or microhemorrhages seen on screening MRI, they were excluded as well. So this is just a summary of what I mentioned. Here's the inclusion criteria over here, the randomization, and the different outcomes that were looked at. We'll also talk about some of the extension phase studies and other longitudinal studies that are being looked at. In terms of results, both patients who received lecanemab and placebo declined over the 18-month study period, but the patients receiving lecanemab declined less. It was statistically significant at 6 months from starting the medication. And patients with lecanemab had about a 0.5 higher scores on the CDR scale compared to patients who were receiving placebo. So it was a positive study, or at least statistically significant. Also, for all secondary outcomes, they were also positive for all of the scoring systems they looked at, as well as they saw a significant less amyloid burden on PET scan over 18 months. And the results were consistent across a broad range of endpoints as well as subgroups. In terms of adverse events, there's something called amyloid-related imaging abnormalities that have been learned to be associated with these anti-amyloid drugs. In patients who receive these medications, they develop both edema seen on MRI scans as well as microhemorrhages. And because of this, patients in the study, they had baseline MRI screening, which we talked briefly about, but they also had another 5 MRI scans, so a total of 6 MRIs during the whole study period. In terms of these amyloid-related imaging abnormalities, they're thought to be related to leaky blood-brain barriers and a breakdown of tight endothelial junctions as we age. And there's 2 ideas of why these form. It's thought that maybe amyloid plaques counteract this leakiness of the blood-brain barrier. And after administration of these antibodies, the plaques are targeted, subsequently eliminated, and they uncover occurrences of these microhemorrhages and edema. Another thought is that the antibodies trigger this immune inflammatory response that inadvertently precipitates these microhemorrhages and edema. One of the most significant genetic risk factors for late onset sporadic Alzheimer's disease is a form of the apolipoprotein E gene called ApoE4, and it's involved in fat metabolism. And it was relevant in this study because patients who carry this gene either as heterozygotes or homozygous carriers, they have a significantly higher risk of developing these amyloid-related imaging abnormalities. So amyloid-related imaging abnormalities were twice as common in the lecanemab group compared to placebo. Most patients who develop these abnormal imaging findings are asymptomatic, about 80% of them. And 2.8% and 0.7% of patients in the lecanemab group had symptomatic amyloid-related imaging findings of edema and hemorrhage, respectively, compared to 0% and 0.2% in the placebo group. For those patients who did develop symptomatic amyloid-related imaging abnormalities, the symptoms were typically headache, visual disturbance, or confusion. In terms of serious adverse events, 14% developed serious adverse events in the lecanemab group versus 11.3% in the placebo group, just showing that these patients at baseline, even in the placebo group, had a high risk of developing adverse events and complications. Here's just a list of other adverse events that happened at a rate of over 5% for patients receiving lecanemab. In terms of infusion reactions, about 26% of patients receiving lecanemab had an infusion reaction compared to 7.4% on placebo. 96% of infusion reactions were mild to moderate. 75% happened on the first dose. And just because you had an infusion reaction didn't mean you couldn't receive the drug in the future, as most subjects, 65%, only had 1 infusion-related reaction. So is this medication a breakthrough or bust? In opposition to this medication and the use of it, there's a questionable clinical benefit. Some of the studies I looked at and some of the literature said that minimally clinically important differences in the CDR scale is about 1 for people with mild cognitive impairment and 1.6 for patients with mild Alzheimer's disease-related dementia. In this study, based on the results, they had a change in CDR scores at 18 months of about 0.5. So there's argument about whether or not that is significant. If I just go back to the scale, you can see that a difference of 0.5 can move you from having no memory impairment or no orientation issues to some questionable memory or orientation issues. So it can switch which category you fall in on the scale. So there's been some argument about whether or not this is significant or not. Other arguments in opposition is the practicality of patients going for all these outpatient infusions every 2 weeks. There's a question of drug cost. It's currently costing $26,500 per patient per year. There's a question of how often patients need MRI scans to screen for these amyloid-related imaging abnormalities. Like I said, patients in this study had 6 MRIs over 18 months, which is impractical in a clinical context, in our Canadian context. So how frequently we need to have MRIs and if we can have this for every patient who has dementia still remains to be seen. Seems unrealistic currently. Patients in this study, they had PET scans to confirm amyloid deposits in the brain prior to starting the drug, which is another huge cost for our health infrastructure. And if they gave this medication to patients without confirmatory amyloid positivity, likely the clinical effect would be even less than it is. And there's a question of whether patients who are going to receive these drugs are all going to need genetic screening because of the higher risk for development of amyloid-related imaging abnormalities that have been seen for patients with that, with the ApoE4 gene. So in defense of this trial and this medication, over 18 months, even patients who just received placebo only dropped about 1.7 points on this 18-point scale. So patients as a whole in this trial didn't get much worse. So maybe the 0.5 points that improvement is a bigger clinical benefit. Also, they only looked at 18 months, and there's a question. It looks like if you go back to that results graph, it looks like the curves are moving apart over time. So there's a question of if you extend this trial and this study beyond 18 months, if the clinical benefit is going to become greater. It was reassuring that they had positive results in all primary, secondary outcomes, as well as clinically relevant biomarkers. And there's a question about optimal timing of when to give this medication. So patients in this study already had mild cognitive impairment and dementia, and they're looking at giving this drug earlier in patients who have imaging findings of amyloid deposits consistent with Alzheimer's disease, but not yet having clinical symptoms. And then there's an argument on a patient-specific level about what is clinically significant or not. We spoke about this a bit in terms of the CDR scale. In one of the secondary outcomes in the ADL scale, they had a difference of 2 points after 18 months, which can be the difference between managing one's finances independently versus requiring assistance. So for an individual patient and their family, that might be a very significant difference. And they might argue that this drug is beneficial for them. So in May of 2023, the drug was submitted to Health Canada, who began to review the drug. It's moved from accelerated approval in the United States to full approval as of July 2023. It was just approved in Japan in September 2023. And there's still some groups who are coming out against this medication, saying not to use it and to be more hesitant and wait for more data. So in terms of future directions, we spoke about this a bit, but there's the AHEAD 345 trial that's looking at giving lecanemab to patients with preclinical Alzheimer's disease. There's this 4-year phase 3 long-term extension trial, which will be interesting to see if the clinical benefit continues to grow over time beyond 18 months. And there's also, they've already published some data, but they've been using a subcutaneous version of the medication instead of IV infusions, which would decrease the cost and the health infrastructure required to administer this medication on a bigger scale. So I think that's going to be very interesting to pay attention to as well. But in short, I think right at this moment, it's currently not feasible in a Canadian context due to the cost and the screening required, as well as the minimal clinical benefit. Well, I think it's going to be interesting to see what Health Canada decides regarding this medication and to follow up on those studies that I mentioned. One last thought I'll leave you with. There was a report that apparently up to 40% of cases of dementia worldwide may be preventable by focusing on 12 modifiable risk factors. Those risk factors include hearing loss, traumatic brain injury, high blood pressure, alcohol misuse, obesity, lack of education, smoking, depression, social isolation, physical inactivity, air pollution, as well as diabetes. And maybe while we wait for more results.
How are you? Good. Does anyone else need help? No. Why? I feel like it. Yeah.
And maybe while we were
I took a skating on Friday.
Oh, sorry, I think someone's mic
that day. Okay, but then my back hurts now, and I'm gonna go into a week of calls. So like, this is to conserve my energy.
Right back.
Oh.
Sorry guys, I think someone has
Oh. Well, that's the thing.
The short of it is that
hey.
maybe our focus should be on these modifiable risk factors while we await for more data to come out.
Any other kidney help?
Thanks a lot for your time.
Nice. But it's gonna get really
happy to field any questions you might have. You can also email me at jfriedland@sap.ca if you have any questions that you don't want to.
It's gonna like start raining. It's gonna go to hail. Then we're getting snow, and then it's gonna go to -15. We're gonna go to +15 to -15. So like, yeah, pickup time apparently weather's gonna turn. It was like 9 degrees or something. Yeah. Yeah.
Don't wear anything.
All kids are good. Does this girl need help? Do you need help? She doesn't have her skates? Oh, okay. I guess so. Your mommy's coming or your dad? Oh, okay. Oh, I have no idea. She's not sure.
Mhm.
Are they coming for sure, your mom or dad? Okay. Do you normally bring your own skates? They usually bring it? Do you go skating normally? Have it. Okay. Yeah, yeah. Okay.
Oh, thanks, everyone.
Josh, are you still there?
Yep, I'm still here.
Hey, it's Josh Landy. How's it going?
Hey, how are you?
Good presentation. Thanks for doing it. I wanted to ask if you happen to know anything about the comparison between this drug and like not placebo, but like what we do now. Whatever the best thing is that we do now. I don't treat a lot of patients in the outpatient setting, so I don't really know. But like, maybe you mentioned it and I missed it. I'm sorry.
I didn't explicitly mention it, but it's subtly here. Like in terms of what we do now, we use cholinesterase inhibitors and sometimes for moderate and severe dementia, NMDA and NMDA antagonists. I only looked at pharmacologic therapy. I never looked at other types of non-pharmacological therapy, which are a huge part of treating patients with dementia and Alzheimer's disease. But specifically for pharmacologic therapy, the only in terms of the ADAS-Cog, that cognitive scale they used in this study, patients' mean difference at 18 months was about a score of 1.44 points difference on that 70-point scale. If you go back to the slide on cholinesterase inhibitors at 6 months, I think their effect was something like 2.7 on the same scale. So it looks like they're not as effective as cholinesterase inhibitors. Now let me find it. Yeah, so on the same scale, the ADAS-Cog scale, mean difference about 2.7. So so it's tough because I think the excitement around these medications is that it's the first kind of positive trial and positive response in a long time. As I said, like these cholinesterase inhibitors, the last drugs that were released were sometime around 2003, I think, and approved for Alzheimer's disease. So it's exciting to have a new medication, but I think there's been a lot of criticism about the degree of clinical response that people have had.
Yeah, it makes sense. Thanks so much.
Mm-hmm. Okay, well, if no one has any other questions, thank you so much for your time. Feel free to email me if you have any other specific questions or any specific comments, and hope everyone has a good day. Thanks.